Well, can I say a very big thank you for you all coming and good afternoon. I know it's been a challenging few days and we're all keen to find out more about what's happening at Dorothy Henderson Lodge and our wider parts of here at Macquarie Park. I guess we've seen a significant team effort at Dorothy Henderson Lodge as we work to contain the spread of COVID-19. And I appreciate that under the circumstances, many of you are concerned about the situation and will have lots of questions. Therefore, the purpose of today is to bring you together so that we can provide the latest information, and particularly from our guest speaker, Dr. James Branley, who will be answering a lot of your questions. And also I've got Kathy Dempsey, who's an infection control expert from the New South Wales Health and an RN, and I got told she's not just an infection control expert, but she's a very, very specialised person. And also Leanne Vidler from Infection Control from the Australian Commission. I think at that point I will say that Dr. Branley is a microbiologist, an infection disease physician. He's worked with the public health system since 1987 and was responsible for the handling of the COVID-19 situation for the evacuees off the Diamond Princess cruise ship. He comes with first-hand experience, and I'll now hand over for him to speak. Thank you.
Thanks, Ross. G'day, everyone. I'm a little bit less formal, so if you want to, if you have a burning issue, I'm happy to just take questions with hands up. I'll just, and I haven't got anything prepared, so this is a Q&A, and so it's informal, so feel free to share your anxieties. I'll just correct Ross a little bit. I wasn't involved in the Diamond Princess so much. I was part of the team that went to Wuhan in China, and we did the initial evacuations out of Wuhan, and then I was in quarantine in Christmas Island for 14 days. And I was very familiar, we had 300 people in that situation, and I was very familiar with the anxiety that this situation produces. And it is, it's normal to be worried, and it's good that you're worried, but you don't want that worry to accelerate to the point where we're all paralysed with worry, because that's not productive to anyone. So, we need to be a little bit concerned, but we also need to find a way of getting on and doing our jobs. And our jobs is looking after our community. And that's what we love doing, and we need to find a way to do that safely and in a way that instills confidence in our colleagues and our patients and the people we work with. And we can do this. We will get through this. We will be okay. We can give you really specific ways of addressing your anxiety. In other words, we can give you ways to protect yourself from this virus. It doesn't magically go through the air and land on people randomly. It spreads in really simple ways. It spreads off surfaces. It spreads off, very close contact with people in terms of droplet spread. So it's that surfaces and droplets that we need to focus on. And the best way of doing that is to clean our hands all the time. Yes?
A sneeze, how close is close?
Less than 1.5 metres is what I'm saying, Kathy.
Yeah, so it depends on what you kind of read, but where, World Health Organisation, for example, say it's within 1 metre. Since COVID-19, we've kind of been a little bit cautionary over that, and we've expanded that to, less than 1.5 metres, but anywhere from that 1 to sort of 1.5 to 2 metres.
So just to sort of illustrate that, Kathy and I are safe currently.
Yeah.
Thank you. Sorry, I'm a feet person.
I'm not going to get it.
Yeah.
Okay?
Right.
Unless we cuddle up.
That's
this
what I wanted to know.
This is what's called social distancing. We do want people to maintain their own personal space, and we can have conversations with people at 1.5 metres quite simply. and we stand back. This morning when I arrived, I got offered a few hands and we did this. So you can actually protect yourself by other people are the risk factors here. So, but you don't need to be miles away from them. This is enough.
For a sneeze?
For a sneeze, yes.
Okay. Somebody sneezed on me at the supermarket yesterday,
Yeah,
and I asked her to cover her mouth.
It's unpleasant. Look, the other thing to say is we are in an epidemic situation, and generally epidemics come and go, and this one, like all the rest, will come and go. And Dorothy Henderson might be the first nursing home to have this problem, but it won't be the last. We will face this in other institutes, and we will get better at managing that situation as well. So I think we can really take confidence that there are things we can do, and it is normal to be a bit worried, but keep that worry under control, do the sensible stuff, clean your hands lots. You should have access to alcohol hand rub, and I feel like I need to now. So somebody grab me a bit, because I just touched a surface and I don't know who's been there, so I'm going to alcohol. So it's really important that we do that. And as you can see, I'm just clasping my hands there because I don't know where they've been. Well, I sort of do, but I think...
You know where your hands have been.
I think alcoholing them is really good, and there's a good way of alcoholing too. Kathy will demonstrate. So you want to get both surfaces of your hands and in between your fingers, and actually get that alcohol around the hands, and that gives you the confidence that your hands are clean. Now, the hands are the vector for this virus. If we catch this virus, we catch it from our own hands. And we do know where those hands have been. And the way we catch it is we rub it in our eyes and around our face. So this is the target and this is the vector. And we have to all start being conscious of our hand-to-face contact, okay? So you have control of that, and you can stop yourself getting this virus by having clean hands and not rubbing your eyes with dirty hands. So that's much more important than the droplet spread that everyone focuses on. If you are dealing with people who have a respiratory virus, so if somebody in your house has a respiratory virus, or one of your patients, or if you're looking after patients with respiratory illness, with respiratory infections, then you do need to put droplet precautions on, and that's where you wear a mask. And if you're going to have clinical contact with them, you know, quite close contact in that 1 metre zone, we would also have you in a gown and gloves. And what we're doing in Dorothy Henderson at the moment in the lockdown situation is that when we need, I go in and I examine the patients if they've got a new symptom, and I will have a gown and mask and gloves on. I still clean my hands lots in that process, okay? And for those clinical people amongst you, you will be familiar with the way you, particularly with you doffing your PPE, your personal protective equipment, you need to alcohol your hands several times in that process. And if you're not sure about that, get some help. There is help around to explain that process to you. But you alcohol your hands at least 3 or 4 times in that process, and it's really important that you do that to keep yourself safe. We have a lot of really good people who have volunteered their time and are happy to do this. There's a lot of people doing it very well, and we should be proud of the team effort that's going on because it's really impressive. And I've been really impressed with the Dorothy Henderson staff. They've really stood up well and done that very well. And somebody else ringing me wanting to talk about coronavirus, no doubt. You know, in years that come, we will regard this as a simple respiratory virus that we're familiar with, and it will normalise in time. I would highlight that China had its first problem at the end of December, and we're now in March, and the situation is cooling in China. So these things don't last forever. They last for 3 months, and they come and go. For many years, we have known we have 3 or 4 coronaviruses that circulate every year that are not this coronavirus but other coronaviruses, and they cause cold-like symptoms and things. The reason we are taking this one seriously is because it's recently jumped from the animal kingdom. And when we get a new virus that comes across from the animal kingdom, we don't know which way it's going to go. But the more and more information we get about this one is reassuring us that the mortality is not that great. However, the mortality is tending to be in older people, so in our populations that we're looking after. And we need to be honest about that there will be some elderly people that might die with this virus, and we will do all we can to prevent that situation. But that's why we're taking it seriously, and that's why there's the media hype about this. It's because it's a new transition from the animal kingdom to the human kingdom, and until that virus sort of gets used to humans, we don't know which way it's going to go, and it needs to settle into the human population. Now that seems to be happening much faster than anyone would have thought, so that's really encouraging. Yeah, another question.
Are people who are recovering, are they developing antibodies? Are they developing resistance to COVID-19?
We believe so. With every other virus, that's the way it works, so there's no reason to believe it won't work that way with this virus. The only hesitation in my voice is because those studies are actively being done, and they're being done at Westmead and they're being done at Prince of Wales and all the other hospitals that are involved in the research aspects of this. And people like me and Kathy are getting 10 research articles a day and trying to sort of condense that and understand exactly what's happening. But it would be very unusual if that wasn't the case, given what we know about this virus. And we know its cousins. We know its cousins that are SARS and MERS, the high pathological viruses. And we know it's less pathological viruses, the other coronaviruses. And we see that in most respiratory viruses. So without saying absolutely yes, we believe that so. Yeah. Yeah.
If there is any area that is infected by a virus, for how long the virus can be alive in that area?
Yeah, really good question. So surfaces like the one I touched before can have virus on them for a little while. And probably the right answer to that, and I hate to be non-scientific, but the probable answer is a little while. And it will vary bit by bit. If you sneezed on the pavement out there where you've got sunlight, the virus is not going to last very long in UV light. It destroys viruses pretty quickly. So the answer to that question is a little while, and it depends exactly on the circumstances. The literature would suggest that it might be as long as 2 days if it's in perfect sort of condition. However, this virus is really easily killed by what we use, by alcohol, by bleach, by all the other disinfectants, the disinfectant wipes that we use. So in general terms, if a COVID patient has touched this microphone or something, we would wipe that down with disinfectant wipes, and that will kill the virus.
Sorry, my question is more to the New South Wales Health. On the weekend, I went to a medical centre at Hornsby to get a prescription for blood pressure pills, and was refused entry into that place. Now, I asked if I could have the script filled out and left to be collected. That's not a problem. Is there any standing orders? Now, the reason I say that is because I told them I work here, but I'm out of blood pressure tablets. So is there a standing order on that?
Yeah, I'll tell you what I think after.
Yeah, I mean, obviously there's been a lot of statements and media releases by the Office of the Chief Health Officer advising and recommending people not to be taking those
tactics, and that we need to provide essential care to those people that need it, regardless of where they work and what experiencing they're involved in. This will spread out to the general community, and certainly they're the things that we obviously want to know so that we can, better inform those people. No person should be left without health care. There may be other processes in place that we can make sure that people get, the right sort of care. But maybe after this we can sort of have an idea of exactly where that was and we can sort of tackle. But certainly the messaging is definitely, if we've got you in isolation, then you're in home isolation. Even if you turn up anywhere because you need something, you're instructed to have a mask on. You shouldn't be denied care anywhere through the system.
Yeah, very true. And if you wear your PPE properly and you do the right thing, you don't need to be quarantined because you are protected by that PPE. What I would say, just in addition to Kathy's comments, and this is not official policy, so I want to make that very clear, but the medical system works on a traditional model of patient come to doctor and, you sit and talk together. And I think this is an opportunity for us to look at that traditional model and see if there are alternatives to delivering healthcare in a less connected way, and a better electronically connected way. And the example that I'm going to use is I run, in my hospital in Nepean, I run the hospital in the home service. And we look after patients who have some risk factor for COVID, and we are looking after them in home isolation. And we are doing that by monitoring them and keeping up to them over the phone. And the phone is a very good way of maintaining distance, and you can deliver healthcare via the phone, via an iPad, via electronic devices that we give to patients and communicate back results. So I think there are novel ways of looking after patients, but I want to reiterate what Kathy said. It's really important as a healthcare community that we provide good health to patients and good healthcare support, but there are different mechanisms for doing that.
I might just take this opportunity to focus on some of the infection control requirements. So obviously we have standard precautions, contact, droplet and airborne precautions. Currently COVID-19 is managed via contact and droplet. Airborne precautions when we do aerosol generating procedures, of which many would not be done in these environments. These are precautions that are your business as usual precautions. So, they set us in good stead for managing normal droplet spread infections, so normal, influenza type illnesses. We're coming into winter. It's about making sure that we're across those precautions normally. And I think sometimes what these types of situations teach us is that, we often let some of those good standards go by the wayside, but it's really important that we manage around standard precautions. So all those things, cough etiquette, respiratory hygiene, washing hands, good environmental cleaning, social distancing, cleaning equipment, protecting yourself for any person who's got, influenza-like illnesses and you need to be close, then you put a mask on. They're the things that we would do normally. But obviously we do need to be aware that sneezing and coughing is a normal defence mechanism. So it's not like everyone's going to instantly stop sneezing and coughing. We have to be aware of that and making sure that people do it appropriately into tissues, hankies, elbows, get rid of them. It's about knowing your cough or, sneezing if you have allergies and things like that. It's about recognising a change and aligning those with symptoms. And James might want to sort of say a little bit more about that. But, I'm just cognizant that, some people get very cranky when somebody sneezes, beside them or coughs. And, but it is a normal defence mechanism that we sneeze and cough. It's about how we manage that and making sure that we're aware of things that are different to that. And any symptoms that are outside of those that may be aligned with an influenza-like illness, then you need to exclude yourself from work. quite often as workers within, providing health, we like to soldier on because, we're very much about making sure that our patients and residents are cared for. This is the time that you really need to take heed and go, you know what, I'm not feeling very well, I've got a bit of a fever, I've got a scratchy throat, I really shouldn't be going to work. Those sorts of things.
Yeah, well said, Kathy. But I think separating when you're worried and you're imagining symptoms from when you genuinely have symptoms is what Kathy's sort of pulling out there. Because many people have a little bit of allergy, a little bit of sinusitis. If you focus on your throat, could it be slightly more tender than usual? I think if you get a fever, a headache and you're unwell, you shouldn't be at work.
What's the criteria that you're testing the residents in DHL and also for family members who have visited over the past 2-3 weeks? They've been contacting us and been told that we give the relevant numbers, but then they call back and say that they won't be tested because they've got no symptoms at that point in time. So what criteria do they use and how can we allay those fears of the people who have visited?
Yeah, really good question. So I think one of the risks in this situation, I'll just go sideways a little bit and then come back to that, but I think one of the risks in this situation is the worried well. So a lot of people worried out there and wanting to go and get swabs, and if they all come to our emergency department at the same time, we're not going to be able to look after the heart attacks, the strokes, all the things that an emergency department needs to look after. So what we want to identify is people who are contacts, and whether they're either close contacts or casual contacts. This is a big suburb, and yet we have a small number of cases in a very isolated area. So if you have sat with one of those cases and had 15 minutes of face-to-face discussion with somebody who goes on to be definitely COVID positive, then you are a close contact. And public health will be chasing those individuals and they'll be on a list and they'll be followed up. Contacts outside of that get much more diffuse as you go out, and it's much less likely that there'll be a problem outside of that immediate close contact group. So what we tend to do is try and identify that close contact group and follow that group quite intensely. And if people are in that group, then yes, they will be followed and have that problem managed. If they're outside of that group, they probably won't, but they might think they should be in that group, and that's the issue you're discussing. And we want to try and avoid too many people trying to insert themselves into the close contact group when they're not part of that group. So the fact that you've worked on this site is not a risk factor. You need to actually have a specific risk factor. Does that answer the question?
Yes, thanks.
Yeah. Okay.
I've got an online question from the live stream. What does self-quarantine mean? How a normal day would look like if advised to self-quarantine?
Yeah, another really good question, because I think unfortunately in some circumstances people haven't quite understood what self-isolation means. So self-isolation really does mean you take yourself out of the community and you stay at home in isolation. If you have support that can deliver, food or other supplies, obviously if there's a need for you to go out into the community, whilst we're not recommending against that, if there's any reason why you need to go, then you need to put on a surgical mask. And those people that are being self-isolated are in fact being provided with self-isolation kits from Ministry of Health that have those sorts of things. Now, about going home to other loved ones, it's about social distancing from those loved ones, so trying not to be in the same room as them, and if there's no way that you can keep that spatial separation, then it's about either putting masks on and just increasing your general hygiene. So if I myself, for example, went home and went, oh, now I'm a contact, I would put myself in the spare room. I would just be saying to my family members, look, listen, just, if you cannot be within, 1.5 metres of mum, like if you can keep your distancing, make sure you use your own towel, cleaning, that kind of stuff. And I have a son who's immune compromised, so I still wouldn't have any worries. I may keep him a little bit more separated, but, I can do online shopping, those sorts of things. I can do a lot of online shopping. But it is really though, it's not self-isolate and then go out to the shops. It's not self-isolate and not go to work, but hey, I can go to the football. It's self-isolation really means you go home and you stay home for the 14 days. And unfortunately, we've had a few cases where they've perhaps broken isolation, and that sets up another kind of dominoes effect for risk factors. And that's probably because they really didn't understand what self-isolation means. There are online numbers that you can ring if you're having issues or you need some additional support, and usually the self-isolating people are being checked in through public health systems across New South Wales.
Yeah, so Netflix and a good book.
And online shopping.
Hi, I know that there's no vaccine for the virus developed yet, but when it is developed, is it going to become available for aged care workers and aged care residents?
Oh, I'm sure they'd be high on the priority list. I think everyone's concerned about aged care, and I think we've learnt some lessons here which will be useful at other places. So I think it's really the group we want to protect are our elderly community members and our elderly patients. And I think the target group for this virus would certainly be people dealing with the elderly and the elderly themselves.
We will get our influenza vaccinations soon as well. Is it going to become mandatory for all aged care workers to have their influenza vaccinations?
You're opening up a chestnut.
Yeah, look, I'm not sure why the decision was made not to make it mandatory for aged care workers. Many of us in the infection control world would have seen that as, kind of a given, and there's probably many political reasons or reasons why at that point. However, regardless of whether or not it's mandatory, local facilities can make their own policies around their requirements for working. And we certainly, even in the hospital setting, took the policy directive and then went, well, you know what? We're going to define this as including this group, and we're going to define this as including this group. So there are workarounds around those things, but definitely, aged care workers should be vaccinated for influenza, because I think that's the concern. We've sort of potentially got COVID-19 and influenza going to meet in the middle, and as we know, we have other illnesses, flus and, human metapneumoviruses and other, rhinoviruses and things that are potentially circulating, that we need to protect the elderly as much from that as we do COVID-19 and our workforce. So it's really also about protecting you guys. So vaccination should be available by about mid-April.
Hi. Just regarding about the symptoms, is there a case that went positive but the symptoms didn't show up, like fever, sore throat, but it's still, is there a case like that?
So normally we look at the infective period as being 24 hours prior to the development of symptoms. So yes, you can be infectious for 24 hours prior to developing symptoms, but that's a very defined period of time. And most people, when they develop symptoms, can think, what was I doing in the last 24 hours? And we tend to sort of look at their activities over that previous 24 hours and try and close any of those gates to to decrease the chance of secondary spread from that time. So yes, but a very small window.
Working at Shalom, very close to DHL, do we have any duty of care towards our families, our young grandchildren, or involved in community as a whole?
So working at Shalom, if you've just worked at Shalom, you're not part of the risk group for Dorothy Henderson. So you don't have an obligation to declare that you work at Shalom, because Shalom is not part of the risk group. That's provided you haven't been exposed to the DHL issue. There was another virus, my understanding, spreading here, and that's an ordinary cold virus, and yeah, that can be taken home and given to your children. It's interesting, but that one is very common in kids, so it's more common for the kids to actually give it to us adults. So kids are a whole risk factor for a bunch of winter viruses, and if you're working at Shalom and you've got grandkids, I'm more worried about the kids infecting you than you infecting them.
So in DHL, the staff of all, I assume, would have been isolated for 2 weeks after being exposed. How is it going forwards now? So the staff that are there obviously haven't been there since the virus has broken out, and if they're in isolation still? Yeah,
good question. So there was, very early on, we've had the infectivity period of this virus, and there has been some discussion as to what the quarantine period should be. We've settled on 14 days, but by far most people present in the first week of that period of time. So we're already well into the first week, and we just need to wait for more data, wait a few more days. But the longer we get through that period, the less of an ongoing issue we seem to have, provided we don't get secondary and tertiary cases. So time will tell, but at this stage it looks encouraging.
And I think just to add on to that, the challenges with these environments is, you know, when we go into a place and we look at someone who's positive, you know, we look at isolating, you know, that pod, which is what certainly was done at the first sort of trigger that there was a potential positive. But what happens, particularly in these environments, you know, you base your care around, you know, inclusiveness. You base your care around, you know, making sure that people are connected through each other. When you start to do the contact tracing and look at things, it's only then that you find out that, you know, index patient 1 actually sat at a dining room table with 5 other people from pod 2 and pod 3. So it did take, which is not uncommon, probably another 24 hours before we actually got here and said, you know what, we just need to actually lock the whole place down in terms of isolation, isolate everyone. Even then, it's about then looking at your precautions. So we've created like a clean zone on entry. You know, as soon as you go beyond that path, anyone that's in there is in a mask. So any of the staff that have basically been in there since that secondary lockdown should not be a contact whatsoever, because they should be wearing the appropriate PPE and hand hygiene and things like that. So I believe we've swapped out the original staff, so we've got agency staff, we've separated management who is probably not at risk anyway, but we've done that. You know, obviously we're looking at food services, and then the next thing would be laundry, but we're actually moving quite well into the incubation period, and the cases that we're seeing still prop up would be based on the original exposure, because we're in that 14-day period.
There's been quite a bit of social media about Macquarie Park, and that's something that the staff here are copying that when people learn they work in Macquarie Park. It's near the uni, it's near where the school that had the positive case was. What's the view on why we seem to have this particular number of cases in this area of Sydney?
I suppose there is some virus in this part of the world, and that's presumably been imported from overseas at some point along the way, and there seems to have been relatively isolated transmission, I would say. Given the number of cases that we've seen, we haven't seen a huge number of cases from Macquarie Park, but clearly the Macquarie Park ride area has had some community transmission, and that doesn't seem to be, really at a high temperature, but it seems to be a low-grade community transmission that's occurred. Now, hopefully, with the heightened awareness, one of the things that will result in that is decreased transmission, and that will peter out, but we don't know.
And I think just to add to that, I mean, some of the epidemiology, so that's the study of the behaviour and the connection of this particular bug, is that they are all seem to be at some point interconnected. So you've got the Ryde Hospital, you've got residents here, you've got, other sort of family members. There seems to be a link at some point. So obviously we still have the connection from overseas. Obviously we've had local transmission, but at some point there's still at this period seems to be a link with that original kind of import from external, and we're obviously just trying to map those, and Health Protection is doing a lot of work behind the scenes to try and track down sort of, cases and things like that. But we also have to be mindful that this is not about blaming anyone who started anything. It's really just trying to understand, how it actually, is transmitting currently, and how we can best control that, in terms of further spread and protecting those that are most vulnerable.
I think we've probably got time for maybe one more question.
We can probably do two.
Hi.
Two.
Hi. I'm just a little bit concerned about the residents at DHL, and you mentioned earlier that if you go out in the sun and and the UV would kill anything, well, most things. But is it possible that some of those residents that haven't tested positive be allowed to sit outside for a little bit? Because I think they're in their rooms, and it's, I'd be going stir crazy myself. But
yeah, look, we've started to have some of those discussions. I was here for many hours on Friday and obviously had those same concerns, but we're all having those concerns. And I guess it's just weighing up, the benefits versus the risk of putting them all together and increasing the risk of spread. I mean, this group are the most vulnerable in terms of risk to them and their health. And we acknowledge it. We're all looking at how best to make sure that they're connected. If they had a little balcony that was, external to their room, then I'd have no problems. But it's really just weighing up. And it does actually make us re-look at how we build aged care facilities. And sometimes, moving towards a more inclusive environment and a social interaction environment almost competes with our infection control and infection prevention aspects, and it's trying to sort of marry those. But we hear you, we most definitely hear your concerns. They are mirrored and replicated across all of those of us that are trying to, manage and guide the system at DHL.
I'm an activities officer, and that's my main problem. How small is a small group that I can interact? Because in my area, it's not locked down. So how close should we be, or how far should we be? We know that socialization is an important component of our care here. So that's one. Number two, I'm a bus taker. And yes, I think about it. The closeness that you said about transmission is something. So I don't want to go panic, but maybe I really will need lots of alcohol. Number three. My third question. Yeah, my third question is, I know that some of our residents are sent to Ryde Hospital. Should they come back to Shalom? Number four, is it possible that would aged care health workers be given or be tested with COVID, so that we just say, do I have it? Do I have, or I don't have it? Is it, I mean, do we have enough of those tests so that we kind of just have a good night's sleep?
Okay, so let's try and unpack those. So the first question was about social distancing. And so some of the simple things that you can do, you can still run bingos and you can still run, whatever social gatherings, but it's all about, hand washing on entrance, cleaning everything down that everyone's had contact with, being aware of people's symptoms, cough etiquette, respiratory hygiene. It's a different level. We're not abdicating that, you keep everyone locked down and no interaction. We do have to go along business as usual, but it's just enhancing some of those things. The second question was... Sorry? Oh, the bus. Yeah, okay, so I'm currently doing some general principle rules to enhance some of the cleaning with public transport, so including trains and buses. And again, that's all just about enhancing the existing cleaning. So, we're not recommending that they all go in hazmats and, spray, because we would not support that. So we're basically looking at just sensible, practical things that help reduce what we call the microbial platform, so the germs circulating. And then it still comes down to, hand hygiene before you immediately eat, those sorts of things, not touching around this area where there's a risk of acquisition. The next question around testing. I think James has gone through that quite extensively around why we wouldn't test you unless you were symptomatic. And the reality is we don't have an endless supply of, swabs and things. So it's about getting those that you can obviously get the greatest return. Whilst I know it's comforting, but we could swab you today because you're asymptomatic and you would be negative, but you could have a scratchy throat tomorrow and we're not going to re-swab you, and that's when you may be positive. So, it's really about understanding and recognising those symptoms and then excluding yourself from work if you get those symptoms. I think, have we answered all of your concerns? Patients coming back from hospital. So, from Ryde Hospital. Well, look, patients coming back from any hospital, and this is a constant dilemma that we have with infection control and, aged care facilities and sending, patients off that have had gastro, that, the nursing home or facility is in lockdown. Whilst we appreciate that, you should be able to take those patients back and manage them accordingly within your environment. If you don't take them back, then we don't have a bed available for the next acutely ill person. So it is a trade-off, but they would normally not be sent back unless they're medically well, and it's really then around your normal infection prevention and control strategies that you put in place to make sure, whether or not they're still communicable or not. So we have strategies around flu, around treatment, and trying to make sure that we get their communicability periods reduced. COVID-19, obviously they may or may not send back until they're negative. It just depends on what else is happening at the facilities at this point in time. They won't send them back if they really don't believe you can isolate them effectively, but it's a discussion between those areas.
What I was going to say was, at least you can get a seat on the train now. Because every time someone sees where you're from, they sort of like... So
Can I just make sure that there's no last questions to the doctor before they have to leave, because time is of the essence for them. And I'd like to thank them in a minute. Yeah. So,
I'm happy to stay for another 5 to 10 minutes if James wants to head up.
So is there any more for James or not? So, may I, on your behalf, express thank you. And can I say very much thank you for turning up most mornings to have a look at the residents there and signing off on them. So thank you very, very much. Greatly appreciate it. And so any more to Kathy? Because I'm going to ask if you'd like to stay. Alan and I can answer more general questions about anything related to BaptistCare, but I would like, therefore, on behalf of you here, thank Kathy for that very comprehensive answers today. So thank you. You're happy to go, or you can happy to stay. It's up to you. Yeah, no, that's all right. Go across and have a look. Yes, wonderful. Thank you. So we're probably more into general questions. You can hang on to that one. I've got this one. So any general questions, more regarding the site, you know, where you're working, that we might want to answer, that you might want to ask?
Or anything about your colleagues that have been working up at Dorothy Henderson, any concerns or queries you might have? Happy to take questions. Perhaps, well, because, okay.
So I'm the scheduler here at Geelong, and obviously the increase of sick calls have been the last few days.
I'll repeat the question. Okay.
How do we ensure our workers here at Geelong that they are safe to come to work and that they're not at risk of this infection?
Okay, so the question is about, from the scheduler for the staff here, that we've had some difficulties with people not wanting to come to work. We wanted to put Dr. James in front of us today to tell us the truth about the risk. And you've heard what he said, even standing this far apart is plenty. So if you can pass this out to your friends and colleagues who work here as well, that he sees that there's no increased risk here relative to anywhere else in the general community. So this thing we've heard about Macquarie Park being a hotspot, we need to dispel that. It's not. It's actually not true.
And that should make your life a lot easier on that basis.
Yeah.
So is it right that we have to remove our uniforms?
No, so someone had said that about removing uniforms. I would hope that you would wear them proudly. Can I tell you just a short funny story that one of the staff, the BaptistCare staff working there, was pulled over for a breath test
on Saturday morning.
And she put a mask on, put a hand up to the window, and then rolled it down this much, and she said to the police, "I work at BaptistCare at Dorothy Henderson Lodge." They stepped back and said, "Off you go." So for her, having the uniform was a protective measure in that case. Not that she would have been any risk at all, but I thought that was quite funny when they told me that. Rahul.
Regarding laundry, we've got a shared laundry, like DHL laundry comes to the Geelong, what is shared?
Yeah, so we have a shared laundry service here, and things from there are still coming here. The laundering process we use absolutely knocks this on the head. So the chemicals that we have, and you'd know this because of we treat normal influenza and other things, and you heard what Dr. James said about how easy it is for the chemical processes we use, including just using foam hand wash, to knock this on the head. So I'm completely comfortable that the laundering process is fine. Yeah. So there are 3 staff members from DHL who have tested positive. All of them are quite well because they're quite young. So, and again, you heard that what they said, that this really impacts strongly for people who are very old. So if you're over 80 and you've got several things wrong, then you can be in trouble with this. And sadly, as we know, 2 residents have died. But young people, and that's all of us in here, well, I'm guessing you're not over 80, Pete, but you might be. And you're well enough to work, so I don't think it includes you anyway. Which is why Dr. James was talking about the plea for us who work in this healthcare industry to continue to show up and come to work to help those people who can't defend themselves from this. We can help them do that. So those 3 staff are quite well. We're in regular touch with their families. Clearly, they were distressed, 2 of them in particular, when they first found out, because it was early in the process of this, and you can imagine the shock that would be. But the three are quite well. And so we have some residents who are in hospital pending results, and they are stable at this stage. That's the only information we have from New South Wales Health. As Dr. James said, we will get through this. I know it seems an almost insurmountable problem when you see people fighting over toilet rolls. And all of you know that diarrhoea is not one of the symptoms here. So why they're doing that, I'm not quite sure. But it just shows the hysteria that exists there. And I think we can help spread a different message that with good basic practices, this can be controlled and managed. And that's where we're headed. So, are there other questions?
Working with aged care probably expose us to many sick leaves or sick days. Are we having extended sick leaves or similar sick leaves like in our organization?
So look, so the question was about having extended sick leave.
Because we've been advised that if you feel even a little bit sick, you shouldn't come.
Yeah, so can we just talk about that feeling a little bit sick? Dr. James said, you've got to be careful not to talk yourself into being sick in these circumstances, because many of us can wake up with that slight sniffle or those sorts of things that he talked about, which are perfectly normal for us every day. What he's saying is that you need to start being concerned if you're developing a fever, so any kind of temperature, you've got a sore throat and a runny nose. They're the things that he was talking about, that's when you need to say, okay, now I really shouldn't go to work. But if everybody who woke up feeling just a little bit concerned, and I think you all know you can talk yourselves into this, we'd have no one anywhere. And so we can't be in that position. In terms of the staff from Dorothy Henderson that have been asked to self-isolate, we are paying them in full for all the time that they are on shift. They bear no blame in any of this, and that won't come out of their sick leave. They're on stand-down pay, and we are doing everything that we can. Even to the point, the hairdresser, who we've asked not to come, we're paying for her wages, even though she's not an employee, because we treat her as though she is. So we're doing everything we know how to do to look after staff. And if something happens in this home or one of our other homes with this dreaded COVID-19 thing, we will respond in the same way. So, but for sick leave, you heard what they were talking about getting vaccinated. That's the single biggest thing you can do as a self-preservation treatment, plus all of the routine things, the hand washing, the not touching your face, and just the basic sensible precautions. I guess that's probably all I've got to say, Eamon, at the moment about where we are with sick leave. Question?
Yeah, I'm going to Japan on holiday in 3 weeks' time.
Yep.
And I just saw the notices up this morning when I came in. If you've been to Japan in the last 2 weeks, please don't come into work. So when I get back from Japan, I won't be able to work.
Yeah, so we are in... Yeah, so we've got a staff member here who is about to head to Japan on holidays in 3 weeks. And the current notification is that if you're in Japan and travelling back, that you shouldn't work for 2 weeks after. And the answer is that's true. That's current government policy on this, and it's likely to be extended that if you travel anywhere overseas, that you should self-isolate following that to make sure. So for people intending to travel, that's a decision you make. And I don't think that it's reasonable that your employer should fund the other 2 weeks at the end of it. If you choose to go, you have to do that knowing that you won't be able to come back to work for 2 weeks following it, with the current policies as set by government. That might change as time marches on and some of the hysteria dies out of this, but that's the current position. I also have some leave booked a bit later in the year, and I can tell you that insurance doesn't cover this. So this kind of medical thing about COVID-19 is not covered. So even for you, even now, if you wanted to cancel, you've probably done your money. But yeah, so but people have to make their own decisions on the risk factors. Do I feel like it's safe to travel, and so on. But yes, you would need to, for those countries listed, self-isolate. Can I just say we're going to do a couple of other things across the aged care homes that we operate in the next day or so. You'll see an increase in some things we're doing. One is around changing visitor hours and changing visitor requirements. We're going to make it mandatory that visitors to the homes have this label on from the printout system. If they don't have it, we're going to ask staff to challenge them about who are you and why are you here, and that they have to go back. In order to do that, we're going to be limiting visitor hours to when the admin area is open. That's going to be a bit unpopular, but for the next little while we think that that's a prudent thing to do. We're going to be stopping groups of school children coming in. You heard what Dr. James said, that they're often the start of some of these things. So, and there'll be some other things that we'll be announcing over the next day or so. Really just to take a really cautious approach to this, to try and prevent it as it gets more traction in the community actually coming into our aged care homes. And we'll be asking people that have travelled from any overseas destination to stay away. So, question?
We work as client liaison, so we show people through. Obviously, we won't be going Henderson until it's safe to do so. What about the other side? So when you're saying about limiting visitors, so we're still getting inquiries.
Yeah, so the question is from... Yeah, so the question is about client liaison and new residents coming in. We will certainly still need to continue to provide beds for people who need them. And so we need to show families through. We're just talking the basic things that as we've been talking with New South Wales Health, concerts that we might run where we bring a large group of school kids in, and those sorts of things will be ceasing for the moment. And we will not be discouraging all visitation. We're just going to limit the hours. We're also going to limit the number of doorways that people can walk through. So for some of our homes, there's 4 or 5 ways you can get in, and families get used to ducking in the back door because it's closest to where mum is. That's all going to get locked down, so that they have to come through the front door. And every time they visit, they're going to have to go through the rapid Google questions saying, has any of these things, if you answer yes to any of these questions, then you can't come in. And I know it will be a bit unpopular, but that's what we have to do. Locally, you need to make allowances for family members that come, and someone might come every evening and sit with mum or help feed her dinner or something. That can still happen. That's an individual arrangement. What I'm talking about is just general visitation will be curtailed for the next little while as we see what happens in the community. And that will be across all Baptist care homes.
So who will monitor if the families are saying yes? If they don't,
Yeah, so the question is who's going to monitor if they say yes to any of the questions that should exclude them. That's why we're wanting it to be when the admin hours are open, and the admin staff will be provided with the script that says this is what we tell them, that unfortunately due to the current circumstance we have to ask you not to come today, and then we can refer them through, we can give them an information sheet and refer them to the public health unit about why we've taken this step. Yeah, so weekends we're going to need to consider what we do with that, whether we try and roster some staff on to allow weekend visitations, but again it will be curtailed. It won't be the kind of open policy we have now where people are welcome to come anytime they like.
Just to clarify, people that don't have family here, but they're just new inquiries, do we need to ask them any questions? What's the policy around that?
Yeah, the question is about people who are new inquiries and people just wanting to come a look. We will put in place a series of questions we'll ask them before we bring them into the building. So they'll be treated in the same way as a visitor for the same reason, that if for whatever reason they're bringing mum in, but they've just been back from Iran, say, then sadly they won't be able to come and we'll need to find another way. All right, I'm conscious you've all been here for a long time and we've got residents that still need us. We can do this again at another time. And I'm happy to come back and do some more Q&A. So one last one. You started the questions, let you end them.
I sit opposite DHL and I can't help but think there's a whole lot of people in there who are, old, frail, scared. Can you tell them that we're thinking of them?
Well, I can do more than that. The thing was that the response here was that we're worried about the residents that are at DHL and can we pass on that you're thinking of them. We can do more than that. There's actually an email address set up where you can write to them. And we've got someone who's taking those emails around to the residents there, and families are using that, but I'm happy to expand that so that if any of you would like to do that too, we'll get you those details.
And Alan and I went through on Saturday and we were able to talk to quite a few of the residents. One of them said to me, "I'm bored." So I think that unfortunately was fairly high on the list. Well, that was Lola Kuzumaka, if you know her, and yeah, she's an interesting lady. So,
all right,
thank you. Thank you for coming. Thank you for your great questions. Well done.